So we all know that spine surgery is usually done with certain indications to resolve and take care of symptoms which may either be mechanical or neurological in nature. And the ultimate aim is to actually improve the quality of life of these patients who are afflicted by these symptoms. And the primary aim in them is to improve quality of life while to alter the natural course of the disease that this patient is going with. And of course, this has to be achieved with the least possible morbidity that ensures the safety of this particular surgery. Like in this patient who's an elderly guy, 64-year-old male with compression of dural sac at L4-5 IS1 level, you would actually want to go and do the best possible job. You did a posterolateral fusion with adequate decompression, and this patient is symptom-free, enjoying it. And posterolateral fusions have really served the test of time. They have served the test of time not only in lumbar surgeries, but in long segment surgeries like in scoliosis, in rheumatoid arthritis, in cervical spine, where you do occipital fixations, like in this particular patient. Posterolateral fusions really have worked well, and it has served the test of time for more than 50 years already. The literature is full of good results with posterolateral fusions. We already see 80% plus fusion rates in adequately done decompression with posterolateral fusion, and it's really a way to go. It still exists in literature that posterolateral fusions does work in many instances, and you can really depend upon this particular procedure. However, it's not a foolproof procedure. It's known to have its own flaws. On more than one occasion, we have seen posterolateral fusion really failing out, even in a patient where you have best chosen the patient for, because of pseudoarthrosis resulting in implant failure. And it's purely because anterior column deficit was happening in these patients. And that led to the inception of an interbody fusion procedure called PLIF, posterior lumbar interbody fusion, way back in 1963, described by Cloward et al. And that's where it said that interbody fusion anteriorly restores the anterior column, giving you not only better fusion rates, but also giving you better lordosis, which also takes care of the morbidity associated with posterolateral fusion. And again, the literature again came up and filled the literature with good results of interbody fusion done with this particular technique, showing excellent fusion results, excellent long-term follow-up. We now actually have 20-year plus follow-up of this particular procedure in various indications in lumbar spine. And mind you, this is again one of the very, very dependable procedures. You can really think about this one procedure to go ahead in most of the lumbar procedures where interbody fusion is required. To further add to the advantages of interbody fusion, or to actually reduce the morbidity of posterior lumbar interbody fusion, which actually led to a lot of post-operative paresthesia due to neural retraction required, TLIF came in. And the transforaminal lumbar interbody fusion, it was all actually meant to have all the advantages of PLIF, whereas to reduce the morbidity associated with posterior lumbar interbody fusion. And again, to ensure the safety procedure, the safety indices of spine surgery enhances to another notch up, TLIF came into picture, and transforaminal lumbar interbody fusion now is the gold standard of interbody fusion, not only in lumbar interbody fusions, but also in high thoracics, higher lumbar discs, where PLIF actually cannot be performed safely. So even in these procedures, transforaminal lumbar interbody fusion is something that you would want to depend upon. And it has shown 97% fusion rates. Excellent 10-year results are also available in literature, and you can actually depend upon this one procedure. All these procedures where lumbar decompression and fixation is performed by open techniques, be it only decompression or posterolateral fusion or PLIFs or TLIFs, have all worked towards one thing: to ultimately improve the quality of life of the patient, while also adding to the safety indices of this particular surgery. However, the morbidity of these open techniques is not low to be neglected upon. The mechanical low back pain associated in post-operative phase, neurological issues like paresthesias, motor weaknesses, neurological deterioration, facet damages while putting in open technique with pedicle screws, reoperation rates are not really small enough to neglect them. And that has all actually led to, even if you see long-term results of post-operative spinal infection, which may range from 3 to 11% in various studies. The reoperation rate actually ranges at the end of 10 years. You'll have 10% of your patients coming back to you for various reasons and would want to have a symptomatic profile getting reoperated. So with the best of open surgery techniques till date, the satisfaction indices in these patients is in range of 80 to 85%. So you actually see that 15% of your patients in a nicely chosen patient with a very, very technically meticulously done procedure, you're still unsatisfied. 15 to 20% of patients will be running around. And all this is purely probably because of early post-operative morbidity, which results in maximum amount of deterioration in the satisfaction indices, where early most post-op morbidity results in less satisfaction in these patients, and 20% of these patients, though will have no symptoms later at a 5-year long-term follow-up, but they still are unsatisfied because of the early post-op morbidity. Yes, complications do add to this list of morbidity, but it's something, a big chunk of patients are really upset because of that early post-op morbidity. So what is going on wrong here? How can we reduce that morbidity up there, which is there in early post-op range in 15 to 20% of patients, and actually increase the satisfaction indices of these patients? Well, the reason for this is purely that any surgery that we are doing is going to have some amount of morbidity. It's very natural to see that any intervention is not natural for the patient, and it's really associated with any amount of collateral damage. To reduce that collateral damage, we often tend to restore upon surgery and try to do what maximum we can do. We all know that all surgeries, not only spine surgery, has got two parts to it. One is the target surgery, where we really want to go ahead in spine, like we want to go and do a decompression, we want to do stabilization, we want to do fusion to these patients. And to achieve that target surgery, we have to go through an access part of the surgery. Unfortunately, it is this access part of surgery which is something that is modifiable and which is also at times responsible for the early post-op morbidity. And that's something where we have got work upon. These access surgery results in stripping of muscles, forceful retraction, resulting in a lot of fibrosis, necrosis, results in post-operative prolonged healing period and residual back pain in the long run. And it has all been studied in literature, proven literature. There is grade 1 evidence to prove that multifidus and various other muscles retracted for a prolonged interval results in post-operative necrosis of these patients with necrosis in the muscles. And long incisions, pain, blood loss, increased infection rate, it's all associated with these conventional open surgeries. So to conclude here, that open surgeries, yes, they have been dependable for most of the indications, most of the patients who have lumbar or thoracic or cervical problems. You can really depend upon these techniques. However, you got to understand that while in an attempt to relieve the symptoms, you are probably adding some morbidity to these patients. And the aim of the surgery now has to change, that we have to relieve the symptoms of these patients, but also have to ensure that the damage to the muscles while this surgery is bare minimum, satisfying the criteria of primum de nocere for any surgery. And that's what found the scientific basis of minimal invasive spine surgery, which said that with relatively small and simple modifications to this access-related surgery, we can really enhance the post-operative experience of these patients, increasing the satisfaction indices. So is MIS that different? Is it really adding to the benefits of MIS that we really intended to set? We set in 2000 to start MIS surgeries, and is it really fulfilling the goal or not? So let's see it. We all need to understand first and foremost that MIS surgery doesn't mean a compromised surgery. It just means one thing, that target surgery is the same. You got to go there and ensure adequate amount of decompression. You are doing adequate amount of stabilization, and of course fusion doesn't get altered. So your target surgery remains the same. What you're intending to do it in open surgery, you can easily do it, and we have been doing it for more than 10 years now. Target surgery still remains the same. It's the access related morbidity which gets reduced, satisfying the criteria of primum de nocere there. Well, we all know that these minimal invasive spine surgeries are of various types. There are endoscopic spine surgeons, there are anterior thoracoscopic spine surgeons, there are microscopic spine surgeons, and there are a mix of microendoscopic spine surgeons now in this world. And it is growing any further. We also need to understand that MIS comes with its own cost. It is a very, very resource intensive surgery. It requires special tools to really be aware about. It requires a radiolucent table, which we really don't use in regular practice of ours. It requires very high-end CIAM. We need to understand that MIS technique really depends upon the radiographic anatomy of the patient, and you have to depend a lot on a CIAM, and so your CIAM has to be really high-end. You got to ensure that your OT is really technically driven, and you got all the instruments that are required to ensure that your salvage procedure is also in place. You got to be aware about these portals. You got to be aware about various other portals. If one is not working, you really want to know that there are other portals to get the access to the definite pathology there. You will want to get yourself ridden and learned with all the new implants. We all know and we are all aware about straight implants, but in MIS surgery, you got to be also aware about the bayonet implants with a certain angle at the tip compared to what you are holding in the hand. Microscope is again another thing that usually we are not aware about in conventional spine surgery. You want to master the technique of using the microscope and endoscopes if you are planning to do endoscopic spine surgery. Mind you, it's not a straightforward thing. It's got a significant learning curve through it, and to get through into the endoscope, spinal endoscopy is not as joint arthroscopy. It is a very different scope that is going in. It doesn't have the same angle that are used in the joints, and so the learning curve here is an entire different one. And so the most important that we need to understand is not only is resource driven, but also you got to be very, very sound in your clinical knowledge, and you got to really master the clinical skills and the surgical skills, which has its own learning curve associated with it, which is a time consuming procedure. The most important thing is not only that you have to be technically sound in this, but also the principles have to be understood. Just because there is something luring out there, you don't want to really resort to it. We need to understand that any surgery that produces same or better results safely with lesser morbidity is called a minimal invasive spine surgery. Just that it has to reduce the morbidity of the patient. It doesn't necessarily has to use that technically advanced portals or microscope or something. You really have to be thoughtful about reducing the morbidity of your conventional open surgery out there. The best example is a discectomy. We have all seen interlaminar discectomies. We have all seen discectomies happening with laminectomies, and subradical discectomies have been performed in past. They have all shown good results, but with further advancements in the technique, now we have forwarded ourselves from laminotomies to foraminotomies to microdiscectomies, and now is there of endoscopic discectomies and microendoscopic discectomies coming up. And it's not just that it's only about saying it out. The early postoperative morbidity definitely comes down. There are advantages which you really cannot neglect upon. The incisions are small. It's a daycare surgery. Most of our spine patients are now going home in the same day. Disc patients, spinal stenosis patients, the blood loss is absolutely minimum. Postoperative pain really weans off in 4 hours. Patients are mobile in like 24 hours. They can resume back to their work in like 3 days' time. Yes, of course, it requires a rehab program, but it is much faster than what it is in conventional open surgery. Just to show you a few examples of our daycare spine setup with Bombay Hospital is a slip disc patient walks in at 8 o'clock morning, walks out at 8 in the evening. A spinal stenosis patient or a sequestrated PIVD. A spinal stenosis again with a minimal invasive spine surgery, microendoscopic decompression, walks in at 6, 7 in the morning and walks out at like 9 in the evening with a dinner out there. And you can ensure that these are all adequately decompressed patient. MIS-TLIF is one way of doing interbody fusion in various indications like degenerative listhesis. In Lytic listhesis, we have been performing this for more than 10 years already, and it has shown really promising results with very, very promising early post-op results. And these patients have very cosmetic scars, as you can note out there. Even trauma, now gradually our learning curve is improving. We are extending our indications. We have used this technique for not only 1-level fusions, but 2-level and 3-level fusions there, and decompression stabilization in patients with trauma. Like in this particular patient where bandage surgery was done, patient walked home the 3rd day out there. Even in scoliosis, now we are attempting more and more aggressive surgeries. In scoliosis also, you can do this microscopic or thoracoscopic surgeries. Like in this particular patient, we did a thoracoscopic correction, and then the scoliosis was corrected, and we really didn't have to go and do a grotesque dissection of muscles in the posterior half of the thing. Thoracoscopic stapling is something that you can depend upon in patient congenital scoliosis, where you can plan a growth modulation in these patients. Thoracic spine has always been really untouched by MIS for the fear of cord, and now we are venturing out there in thoracic spine, not only in the simple disc, but also in tumor patients where we have did MIS stabilization. These are all patients which require palliative care, and MIS is something that you can really depend upon. Vertebroplasty and kyphoplasties have stood the test of time in patients with osteoporotic fractures. And now we are entering and venturing into the cervical spine. This is one patient where we did a posterior and anterior foraminotomy. Posterior foraminotomy is for a far lateral disc in cervical spine is something that is very, very famous, and it has been proving its own worth in long term. And now we are doing high cervical instrumentation, like in this child, 5-year-old guy with atlantoaxial instability, and we did a minimal invasive transarticular fixation in this particular patient. So what I'm trying to say is that the indications are just expanding. It started with disc. Now we are heading on to metastasis in lumbar spine, anterior reconstructions in lumbar and thoracic spine, both cervical spine, all the way from low and subaxial C spine to high occipitocervical fixations are all amenable to MIS surgeries. And the benefits, as we just discussed, it's not something that you can really neglect upon. Can I at this point say that MIS is the new gold standard and it's a foolproof treatment, and all my patients I would want to treat only with MIS surgery? The answer to this is definitely no. There are definite downsides of MIS surgery which really cannot be neglected or thought upon. This is something that we all need to be aware about, that MIS is a C-arm or a radiation guided surgery where radiation hazards are something which is very, very serious concern and coming up now. Percutaneous instrumentation means depending a lot on C-arm, which is not a very reliable source of instrumenting the spines. Your tactile feeling of bone is really offset, and you completely depend upon the C-arm that you have got to instrument on these patients. Fusion rates are doubtful. Cost efficacy is something that we really have to prove with long-term studies, and there are new complications with new technique, salvage of which is yet to be defined. The beneficiary indications are also limited. You really cannot do this surgery in a 3-level, 4-level elderly patient. It has its own time limits. You cannot really depend upon this in every patient of yours which requires a open, and sometimes you would want to depend upon an open surgery more than this. It has a very steep learning curve. You want to put in your brains into it, your time into it, and it requires really getting aware about the new technology also. The complications are newer, and it has not been shown that MIS has reduced any amount of complications of open surgery. Yes, it is matching with the long-term results of open surgery, but when it comes to complications, MIS surgeries have not shown to reduce any amount of complication that an open surgery would actually produce. And though cost efficacy is in favor of MIS surgeries in terms of hospitalization times and reoperation rates or blood loss, but still by far and large at long term, the cost efficacy of MIS surgery is yet to be established, which gets marred by costly implants available till day. And And as I said, instrumentation, even with the best C-arms available, the perforation rate of screws done by percutaneous instrumentation techniques is 15%, which is not a small one. And the most important and the very strong and serious hazard is radiation exposure of dedicated spinal surgeons, which in cumulative long run really poses you a serious threat of developing cancers, both solid and visceral and hematological malignancies, which is far more common in patients who, in surgeons who are dedicated MIS surgeons, depending completely on the radiation technology completely. So again, now at this point with so many downsides, does that mean that our future has already gone by and we are not going to head ahead with MIS and that's the end of the era of MIS? I think no, we have really found new wings to fly high with this MIS, and that's navigation guided techniques. Dr. Malan just spoke about navigation in joint replacement techniques. Navigation is paving its way in spine also, and navigation, though in very, very infantile stages of its development in spine surgery, but it still made its way. We all are aware about the technology of navigation. It's purely like parking your car in your parking lot without really seeing back. You can completely depend upon your cameras where your car is going to get parked out there, and the GPS systems, we all know that it gives you a predetermined path where you would want to navigate your car into, and this is all the technology of navigation which works in spine also, and it gives you a predetermined path on a computer which can be accessed by all the trackers there, and the advantages are very obvious. You get a better visualization, the precision of implantation is far higher than only percutaneous systems, the complications are far lesser because of instrumentation, and it reduces significantly, very, very significantly, the radiation exposure rates into this. This is one such example where we started our first case. We did a 3D guided, CT guided navigation, and an open lumbar spine surgery was done. This is one such picture which shows you completely intraosseous placement of the screw, and the perforation rates have been dropped down to almost less than 3% in these patients. Not only in open surgeries, now we have ventured into the MIS also, and minimal invasive spine surgeries have got new wings to really fly upon with navigation technique. The radiation has come down far significantly than what we would do with a radiation guided thing. This is one such case where we plan to do an interbody fusion, and this is one such example where MIS fixation was done with a navigation technology. Not only in regular lumbar spine, in kyphoscoliosis, in kyphosis, not only instrumentation, but planning of the osteotomy. If you see, a very highly precise planning of osteotomy was done with this help of navigation technology, where we planned the amount of bony wedge resection, and three-dimensional osteotomy was planned with the help of navigation without taking actual shoots and radiation there. And that's how the pre and post picture looks like for this patient. And as we just saw, navigation guided C1, C2 has now a new kit to the block. We have did more than 10 cases of transarticular screw fixation with navigation in spine surgery, and we are really, really happy with the early results of this particular technology. Extremely wonderful, precise placement of screws out there. Lateral mass is another thing which we did last week. This is one case where we did lateral mass fixation only with navigation technique. It's easy to say that navigation is usually not required. I can easily do this with my own free hands, and I've been doing this with free hand. Yes, it's easy to say that, but mind you, the critical analysis has shown that perforation rates without navigation are high, and navigation definitely reduces the perforation rates and places more accuracy and placement. And there are advantages which really cannot be neglected. The most important advantages of navigation would be in a complex deformity where X-rays and C-arms are of no worth, where you can really depend upon it for not only placement of your implant but also placement of your cages anteriorly. And there is enough literature now coming up with class 2 and class 3 studies showing that navigation is the way to go ahead if you are planning to do MIS. The most obvious advantage is that it reduces the radiation exposure of the surgeon in MIS surgeries, where it reduces the risk of radiation hazards for the patient, for the surgeon per se. So to sum up this all, conventional surgery, yes, they have served the test of time and you can really depend upon in most of your cases. However, it is no more the gold standard of spine surgery today, and MIS can and has been producing better results with minimum approach and minimum approach related morbidity. The primary goal of primum de nosa can very well be settled by MIS surgeries. The benefits of keyhole surgeries cannot and should not be neglected. You cannot really withhold the benefits of MIS surgery from these patients. Navigation has given us wings to fly upon in these new MIS surgeries, and believe it or not, MIS surgery is the future and it is here to stay with you for long. Thank you so much.